Thank you, Jenny. Thank you, Charlotte. Can you all see my screen? Jenny, can you comment? Because
Yes,
I,
yes, thank you.
yeah, okay. Thank you very much, first of all, for inviting me to speak in the very first meeting on the physiotherapy lecture series. I'm really proud that I'm giving this talk. And physiotherapy is an integral part of any chronic pain team. And we rely a lot on your help with regards to assessment, management, and working as a team. I didn't know where to pitch with regards to long COVID syndrome because it's quite a relatively new syndrome and disease, and there is still lots of research coming in. I'm presenting whatever evidence is available at the present time and what we can do to manage. Most of the management strategies relies in the hand of a good physiotherapist and team working. So that is why I think this topic is very, very topical among all the delegates today. I had to tell I have been practicing Inspire for the last 3 years, but I'm going to have a small break and come back. But there are lots of my pain colleagues Inspire who can take the referrals, as well as I work in NHS still with long COVID syndrome and other chronic pain conditions. So thank you, Charlotte, for the introduction. I'll see whether I can move the slides now. Yeah. Uh, this was 3 days ago on Sunday Times. Why is Britain now the capital of long COVID? So it is a pandemic after the pandemic. So it is still what we are seeing is a tip of the iceberg. There are lots of patients who have suffered with severe COVID infection, and they're all having still symptoms even after 12 weeks or many months and are having the syndrome called long COVID syndrome. So this talk will deal with this, as well as if you go to your Association of Chartered Society of Physiotherapy, there are some sort of key guidelines also, which I'll be covering towards the end. So obviously, this is a very, very important topic for CPD needs for physiotherapists, as well as you'll be seeing many of these patients in your day-to-day practice very soon. So that is why I wanted to cover the topic. So what I'm going to do is, my plan is to talk for roughly around 30 to 40 minutes and then have lots of questions at the end, because I feel that questions and discussions are going to be more important part in making this more interesting. If there is any problem with the slides or audio, please put it in the chat box and Jenny will let me know and stop me. So I'm going to deal this in three parts. Number one is there a long COVID syndrome? Why does it happen? What is the pathophysiology? The second part is, of course, symptom management is the main part of the treatment, but I'm going to concentrate a bit more on pain management, which is my specialty. And the last thing is, if it doesn't settle with your expertise, what can we do? What are the techniques available? So that is what I'm going to deal with. Edward Munch scream. I'm sure most of you are familiar with this picture. This is a typical picture, although he drew it for existential angst. This is a typical picture which depicts the fate of a person who is in pain, like chronic pain or pain due to long COVID syndrome. They are depressed, they are frustrated, they think that nobody else believes their pain, and they go down a vicious cycle, down and down. So it's going to be a boring topic. So I'll start with a small joke. If you know this joke, I'm sorry for this, but let me start with a small joke to make it interesting. So Boris Johnson announced that we are going to extend this lockdown by another 4 weeks. So we all got a bit worried, and my wife was depressed, and she was saying like, oh, we can't go. We have been housebound for 15 months and we can't go on a holiday. So I said, like, to console her, okay, we have got a big world map on the wall in our living room. So I said, put a dart. You can throw the dart wherever it hits. Once the lockdown is ready, we go for a 2-week holiday. So she said, really? Wherever in the world? Yes, I said, we can go wherever in the world. Wherever the dart goes, I will take you there for 2 weeks. Apparently, the result is that we are going to spend 2 weeks after the lockdown is relieved behind the refrigerator. So jokes apart, long COVID syndrome is a real syndrome. It does exist. We believe the pain. And we know, I'm not going to go to the basics of COVID. COVID is a disease which is in news every day. So talking more about COVID is going to be a boring thing for you. So the coronavirus or SARS-CoV virus 2 was first identified in Wuhan. Everybody knows that. So in acute disease, which is contagious disease, you have symptoms of fever, cough, fatigue, breathlessness, loss of smell, loss of taste. And of course, there are variants after variants coming. And even the Delta variant has more variants now. So I'm not going to go into the basics of COVID, but we know that COVID is a disease which has destabilized the whole healthcare system. It has changed the way we practice our day-to-day activities. So there are complications due to COVID itself. As you can see on the left side of your screen, The neurological features of COVID: smell dysfunction, taste dysfunction, headache, dizziness, loss of consciousness or impaired consciousness. These are acute stage features. Of course, we know from previous experience with SARS or MERS, the respiratory viruses, that these viruses can cause lots of similar symptoms like sleep problems, traumatic events after and the post-traumatic stress, emotional problems after these viral infections, concentration, fatigue, memory. So there are lots of links between these sort of viral infections which comes in an epidemic. Moreover, as a background, I would like to tell you that those whoever are physios have worked in intensive care, you all realize patients who have been stuck for a long time in intensive care, they go on to develop this intensive care neuropathy or myopathy because they have been ventilated for a long time. They go through hypoxia, they go through lots of medication related side effects. They have muscle relaxants for ventilation and intubation. So these people develop a lot of weakness, and it is a known entity in intensive care already, even before all this COVID came. And we know that these patients suffer with cognitive problems, physical problems, even psychological problems like PTSD or post-traumatic stress disorder after this. Chronic pain after intensive care admission for a long time is a very, very known entity. Lots of patients suffer with that. There is huge amount of evidence which I'm not going to go through. Of course, it can even affect them even after 5 years after the intensive care admission. Even before all this COVID, this data was available to us. We also know that 1 in 3 or nearly 1 in 3 of ARDS survivors or acute respiratory distress syndrome survivors will end up with post-traumatic stress. So we know that intensive care viral infections can cause problems. So that is our background knowledge before all this COVID came. Then came this long COVID. People who had suffered with severe disease, many of them recovered, majority recovered, but there is a small proportion who went on to suffer a lot. They became healthcare consumers, and 1 in 5 or 1 in 10 suffered with this syndrome called long COVID syndrome, which was first described in May 2020. So majority of the people will recover, but some still go on to have fatigue, shortness of breath, brain fog, pain-related problems. World Health Organization recognized this in October, saying like there is a serious long-term effect and it is a pandemic after the real pandemic. So we knew this nearly many months ago. So the main problems we noticed first was fatigue, headaches, exhaustion, and mood swings. Of course, this was recognized in British Medical Journal last year, saying that nearly 10% suffer with prolonged illness and they recover slowly depending on the support. It is mainly symptom management, as you can see here, holistic support, rest, and gradually increasing in activity. Who else can do that apart from physios? We are all experts in doing that. Of course, it can cause respiratory and cardiac problems in some patients. I'll come back to assessment later on. So it is a known entity. It does happen. And there is a huge amount of social media cry from these patients that nobody is recognizing them. Nobody is realizing, nobody is believing them. So there are lots of social media outcries. There are Facebook pages, there are websites for long COVID SOS problems. I will discuss that at the end. But patients do suffer with problems even after 100 days, 200 days, and it's keeping on going on. So we know that most people recover within 2 weeks, but there are a proportion of patients who can suffer long COVID syndrome. So it's a big morbidity and burden. These are all long haulers, and it is going to be a big pandemic, and it will be affecting your way of work, the way of work, what we do in chronic pain clinics, because these patients will be coming back to us after going to a revolving door phenomenon of seeing many specialists and then go on to a chronic disease and come back to us. They will have fatigue, joint pain, palpitations, headaches, dizziness, insomnia. Pulmonary scarring and dysfunction is a known entity. We see that on the CT scans and X-rays. Cognitive dysfunction is very well reported. 1 in 3 go on to develop neurological symptoms. 1 in 5 develop hallucinations, confusion, and agitation. And 42% of COVID infection patients can have delirium. This is what evidence shows till now. I'm sorry for this busy slide. I'm not going to go in detail about each and everything, but these are known symptoms to last long, not just in UK or any other country. All over the world, there are studies to prove that patients can suffer for a long time after the actual infection. What are the common symptoms? The Italian study showed that fatigue, shortness of breath, and pain are main problems. And pain can be joint pain, chest pain, muscle pain, headache. There are a variety of pain which is listed here. I'm not going to go in each and everything, but patients will come with fatigue and pain, typical chronic pain symptoms, and they will be referred to physiotherapists. Of course, delirium happens in COVID infection due to various reasons, because already it is a frightening situation of having patients with PPE and all ventilatory stuff in intensive care. They are not allowed to see visitors, long-term ventilation, medication use, hypoxia. All these things can affect their neurological status, and those are the proposed causes for having delirium. What is the theory behind long COVID syndrome and persistent neurological problems related to that? Of course, I'll start from the left side of your screen. Risk factors include advanced age, having lots of comorbidities, especially renal and cardiac comorbidities, high blood pressure, diabetes, obesity, and respiratory problems. So there are inflammatory causes. I'm not going to go into each and every detail, but you can divide it into three main things like hypoxia-related pathology, ischemia-related pathology, and nerve injury-related pathology. So patients do suffer with hypoxia. We all know that because of the lung-related changes due to the COVID acute infection. This hypoxia can do damage. It's the same thing we see in SARS virus or other respiratory viruses also. The additional problem with COVID is the vascular causes. We all know that they end up with coagulopathy and thrombosis if there is a significant cytokine storm, which is the mediators of inflammation. These can lead to ischemic changes, and that can also cause persistent problems in the long run. This is the second proposed theory. The neurological theory is that there is lots of vasogenic edema, oxidative problems, and there are like glial cells in the nerves which are activated. These can all lead to this long COVID syndrome. Of course, if a last thing is like hospital course, if they lose the circadian rhythm, they are sedated for a long time or paralyzed for a long time, this can increase the risk of developing long COVID syndrome. So there are risk factors for chronic pain in long COVID syndrome or after COVID infection, which Kemp and Corner have elicited. This paper came out in October, and we still hold this true. So there is a high risk of developing long COVID if the patient has a pre-existing mental health problem. If they have acute pain, they develop chronic pain. We know this from post-operative course, but again, this is proven in COVID syndrome. And if they have comorbidities, the risk is high. And there is ICU-specific risk like having long-term ventilation and neurological insult. So there are high risks in these sort of patients. And there is a challenge with the rehab, especially the problems you will be facing, because these patients have multimorbidity, and there is a high incidence of fatigue in these patients. And already our system is overburdened with physiotherapy and pain clinics having such a long waiting list to catch up. So there is going to be a huge burden of rehabilitation in these patients. So with that, I have proven that long COVID is a known entity. We are going to face a huge problem in future. You're not going to avoid it. You're going to see it in your day-to-day practice. Already my clinics, I'm seeing a lot. I'm seeing at least 1 to 2 patients every week with long COVID. At least I'm telling minimum, specifically with long COVID. Added to that, there are many cases which are not diagnosed. They come with query fibromyalgia, but they might have had a significant COVID which has made it worse. So you will see these patients very often. And the next part I'm going to go is looking at what are the existing guidelines. I'm going to talk in 3 parts. Number 1 is the NHS plans, what the NHS proposes to do with these sort of patients. The NICE guidelines. NICE is the Bible of healthcare, as we know. This is where that is what is the basis for commissioning of services. So NICE guidelines have given some sort of management strategy, which I'm going to go through. And patient-related association guidelines like ABME associations, they have recognized this. I will come to that also. So NHS recognized long COVID as an existing entity, and Sir Simon Stevens, NHS executive lead in October, proposed a NICE guidance to come out. And he said there is a rehab recovery program online as well as looking at hospital-based services. And he allotted a funding of 10 million to start, but of course that is just a small drop in the ocean. We need more, because the 10 million was to look at designated COVID assessment services in 80 places. Then we looked at the NHS also proposed that National Institute of Health Research will fund research on long COVID as a priority. And he set up a long COVID task force within NHS to look at how to deal with this in future. So the message is Yes, this is going to be a problem in the long term, and NHS recognizes that. So what is post-COVID syndrome and how do you define? NICE has given guidelines. They work with Scottish Intercollegiate Guidelines as well as Royal College of General Practitioners to bring out these guidelines. So any sign or symptom after an infection consistent with COVID, they don't need to have a swab to prove it, but if they had COVID-19 like symptoms and their symptoms persist after 12 weeks, that is called as post-COVID or long COVID syndrome. There is a small difference in terminology, which I'll come later on. So this is the guideline. If you go online, you can easily see. I will send, Jenny will send all the slides to you later on if you want. So there is a nice guideline 188, which deals with COVID-19 and long-term effects. So this is very, very important. Go through that when you have time. So I will summarize it. What it says is up to 4 weeks, terminology is acute COVID. So if they have an infection and if they have symptoms for 4 weeks, that is acute COVID. So we all know that. We see lots of these patients in the hospital. From 4 to 12 weeks, it's a borderline. So if the symptoms persist, still most of them recover between 4 to 12 weeks. So we call it as ongoing symptomatic COVID. That is the terminology used, as you can see here, ongoing symptomatic COVID. If it lasts more than 12 weeks, signs and symptoms, and there is no other diagnosis available, we don't want to miss any cardiac or respiratory problem. So all the diagnoses are ruled out, in which case that is a post-COVID-19 syndrome or post-COVID syndrome. From 4 weeks onwards, we can terminate it, we can give a terminology as long COVID, because it is ongoing symptomatic and post-COVID, both are included in long COVID. Of course, it's just the terminology which differs, but of course, long COVID starts from 4 weeks. That is what it says here. Post-COVID is the actual syndrome which denotes the chronicity. So these are the terminologies used for research purposes. So what does NICE say? NICE says that these patients, when they have symptoms, we should offer initial consultations. It could be either a web-based or video-based or phone-based or person-based face-to-face appointment. We need to have a screening and assessment. We need to identify the high-risk patients, 2 high-risk groups. One is the BAME group and the patients who have lots of comorbidities. And if the patients have symptom managed, then 6 weeks after discharge, you need to follow up. That is what the guideline is in secondary care, to make sure that these patients have recovered rather than leaving on to go on to chronicity. Assessment, the pathway, what NHS NICE guidelines and NHS management suggests is holistic patient-centered approach. Of course, it's the same for any chronic pain condition. We use a biopsychosocial model. We listen to the patients and take a patient center, because each patient has differing presentations. Some have respiratory symptoms, some have fatigue and pain alone. So it varies depending on patient. Individual plan for that patient is what is suggested. Comprehensive clinical history, and then assessment looking at 5 different domains. Physical, how does it affect the patient physically, respiratory wise, cardiac wise, musculoskeletal wise. Cognitive is the second one. Cognitive, definitely there are lots of problems with memory and brain related things. So cognitive assessment quickly. Psychological, how it affects the patient as a person, and psychologically does it affect, do they need any further support apart from us looking at getting team help from counseling or psychology sort of thing. Psychiatric, so they can get significant anxiety, depression, post-traumatic stress. So we need to realize that and ask some questions related to that. Last is functional ability. Of course, any physiotherapy or chronic pain clinic looks at quality of life and function. So we look at what has it stopped the patient to do. Today morning, I had a patient who was a very senior executive in the school and teaching domain, and she has dropped all her job and gone to work part-time because of long COVID syndrome. So it does affect, and patients always come and it doesn't affect them alone. It affects the whole family, their financial status, and it is real. This was a person who was performing to a very high level till last June, and suddenly COVID comes and they have deteriorated. So we have engaged this patient in a multimodal biopsychosocial model, and the main thing is to give them confidence that they can recover. I'll come to those points later on in the treatment side. Do they need investigations or referral? Yes, if the patient has a significant respiratory problem, the guidelines suggest that they need to have chest X-ray and looking at lung functions. Blood test, if to rule out just other causes like cardiac cause, we don't want to be missing a cardiac cause or inflammatory cause. So they suggest a common test which a GP can do of full blood count, use and ease, and inflammatory markers. The exercise tolerance, of course, we do that in your day-to-day practice. So sit to stand for 1 minute, looking at breathing and saturations. Postural symptoms. Many of these patients go on to develop POTS or postural orthostatic tachycardia syndrome. So POTS is a known entity in these patients. So BP, lying and standing, and heart rate. If respiratory symptoms are there, chest X-ray, as I said, and looking at psychology or psychiatric assessment if the symptoms are affecting them. So the management mostly looks at self-management strategies. I know all the physios are very good at looking at this. So what we do is we give them the confidence, we recognize the symptoms and tell them how to manage it. Integrated multidisciplinary assessment service is important, especially if they have cardiac or respiratory symptoms, they need to be referred to the right service. But at the same time, giving them the confidence and looking at gradual recovery, slow mobilization sort of thing. Specialist care for specific complications, because there is a very small percentage who won't go on to develop a long-term respiratory and cardiac problem, and they need to be managed for that. Phased return and slow recovery is a norm. So we know that, and we need to look at that and make goals appropriate to that condition. And we need to follow up. So this is the NICE and NHS guidelines. I've gone very quickly, but I'll send you the slides. There are references, so go and have a look if you have time. The myalgic encephalitis or ME association were the one. And there are lots of patient associations who have bought guidelines. If you go to NHS, NW, there are like guidelines there also. I will send the link. But this guideline I have selected because it came out very early in September itself last year, and they focused on patient-related management. That is why I have put that here. And they realized even in September, within a few months of COVID, they realized that more than 60,000 patients were suffering. If you take 1 in 10 or 1 in 5, these numbers have gone very high. And we are going to see a big floodgate opening with all these long COVID patients later on. And they used a COVID tracker, and they said like more than 12% reported that the symptoms lasted more than 30 days, which will easily fit with the long COVID diagnosis, which equates with what I said, 1 in 10 will suffer with these symptoms. 1 in 5 to 1 in 10 is the number, but they have said 12%. Fatigue is the main symptom. So these are the things what we as a pain management or chronic condition management healthcare professionals can help with. So there is a pathway called Your COVID Recovery from NHS. So they set up long COVID assessment centers, 80 centers. It is available on NHS where they are recovery and rehabilitation platforms on apps on the phone, and they looked at pain management. So with that, I will stop the guidelines, but the summary is there are guidelines available. Each association, like the Chartered Society of Physiotherapists, have given some guidelines, which I will cover later on. And the main key is it's the same as any other physiotherapy condition, assessing them, communicating, looking at self-management and working as a team. That is the goal for chronic condition, more so in long COVID condition. So I will come to now to symptom management for the next 5 to 7 minutes. So looking at how to manage fatigue, breathlessness, mental health problems, pain, and when to refer. Of course, you're all experts, and I'm sure you all know more better than I have learned from physiotherapists looking at breathing exercises, how to mobilize sort of things. So you are all experts. I'm not going to teach you those things, but what are the guidelines and what are the recommended strategies? That is what I'm going to look at. And what is the evidence? That is what I'm going to go through quickly. So fatigue, pacing, of course, we know how to pace, and we use various strategies. There are lots of websites and guidelines. I'm not going to go into detail, but slow pacing, simple strengthening exercises, and making the patient accept that slow recovery is the goal, but will steadily go there. That is what we need to tell them. Breathing exercises. In chronic pain, I use the Breathe to Relax app, which is on the left lower bottom. It's a very good app. I have extrapolated to use this in long COVID syndrome also. It's free to download from National Center of Telehealth and Technology from America. It's a very good website. I practice it myself using this app. And of course, the deep abdominal breathing, personally breathing, or using breathing with some pictorial representations. You can use anything. But the main thing is getting them confidence, and if they have respiratory symptoms, depending on the patient, using the appropriate technique to look at strengthening the breathing, respiratory muscles, and breathing exercise is the key. I think this will go a long way, because patients all will say, yes, I've seen these exercises, but the main goal is to make them practice these exercises or show them how to practice is the key. Mental health, of course, tell the patients to be kind to themselves and looking at social integration, because patients are still worried they don't have a diagnosis. That is the key. But making them realize this, yes, you've had all the tests, This is a known condition and we have expertise. If you give the message and ask them to look at slow, gradual recovery and staying active, that is the key with regards to this. Memory problems and cognitive problems are a big problem in recovery in these patients that I've realized. So looking at distraction strategies, memory-wise, making notes, planning things. So don't forget this, because these patients can end up with significant brain fog, like all our fibromyalgia patients, and this is a known entity. And most of the patients I've seen writing down notes and bringing a list of questions. So these patients need time to be talked to. Pain, of course, any chronic pain condition, look at strengthening exercise, flexibility exercise, teaching gradual movements. And I'm sure you are all experts better than me to look at these things. But the main thing is to keep them moving. That is the key. Of course, there are physiotherapy services in the community. Of course, look at getting some help from counseling or people who have CBT or ACT, acceptance and commitment therapy support. These will go a long way in recognizing the yellow flags or the flags of catastrophization, abnormal fear. If you realize those patients, it's better to get some help in the community. So work in a biopsychosocial model for pain management. We have not had great help with medications, but of course, for the acute stage, they might need medications to help with them. But the goal is to look at physiotherapy and functional restoration. Trying to use non-pharmacological techniques depending on what is available in your setup is very good. In NHS, we do have access to acupuncture, TENS, and complementary therapies. So we use them a lot, and that gives them a rapport to link with our service and engage in our service also. Analgesic evidence is very limited. Of course, we extrapolate the evidences we have in neuropathic pain or other chronic pain conditions and use it in long COVID because it's too early to say whether these are working. My personal experience is to avoid opioids because it's the same problem in chronic pain. Opioids reduce the immunity. It weakens the bone. It causes hormonal problems in huge doses in long term. So if you're using for a short course, that's fine. But in long term, we don't give opioids. Of course, we try to use neuropathics, but then you have to assess after 4 weeks whether it is really helping them. Because the problem in neuropathic medication is the number needed to treat is 4, which means like 1 in 4 get benefit. So you don't want to be missing the 3 who will be continuing to take medication and not stopping them. So reassessing after medications, but there is a role, but it works along with a multimodal team management rather than medication alone. So I'll come back to what Chartered Society of Physiotherapists message is. Of course, it's available on the website. And what they say is the key message for physiotherapists is collaboration with the patient. No one size fits all. Because I've told you this is a pathway, it doesn't mean that it will fit the patient. Each patient is different. Screen and assess for neurological, cardiac, respiratory, and pain problem. That is what I've told you earlier. These 4 domains shouldn't be forgotten. Symptom assessment and management. Don't look at cure, but how to improve the symptoms. Give hope is the message that CSP gives in abundance. The reason is these patients are already feeling low and depressed, and you need to give them hope. Of course, it's a new condition. We know to a limited extent. That is what I tell my patients. But our evidence shows that if patients engage in keeping active and if they can take control of their pain with regards to the mood, they get better. That is what the science proves. Work with others as a team. Some patients will need respiratory physios or cardiac physios or may need some investigation. So we need to work with others depending on the symptom. Making a structure and routine, of course, physios are very good in that, I know that. And incremental approach, start low, go slow is the key. That is the most important thing. Looking at our emotional well-being and sleep. And the summary is be confident, but be steady and patient. You're not going to see miracle, but you will get there. That is the message. And we need to follow them after some time to make sure they are on the right track. So what can pain clinic do apart from what you can do as physiotherapy? I will honestly tell the majority of the things what I have told you, physiotherapist can do. They are the key. I myself refer to physiotherapy within my team. And that is the basis for functional outcome, quality of life and things. But when you assess, if you look that there are like chronicity markers, that is what I call as yellow flags. Patient who doesn't believe that they are going to get better, patients who feel depressed, patients who don't want to engage in the treatment, they are not going to improve. Of course, we know that from our experience. And despite your treatment, if they are not improving, think of referring to the pain clinic and we can help. And how do we help? There are a variety of things any pain consultant can do. Of course, the common things in my experience that I have used in this short duration of my limited experiences. I've used lots of infusion therapies. If a patient suffers with headaches, we do routine blocks like greater occipital nerve block or Botox injections. We have extrapolated our experience and used it. We do regional blocks depending on pain where it is. We do blocks also, but we don't rely on injection alone as a thing. It is to be done in a multimodal way along with other things. Injections have limited evidence. They are not a cure. Why am I specifically considering infusion is there is a huge belief and theory behind intravenous lignocaine infusion. We use it a lot in Leicester Pain Service and Spire Leicester for chronic widespread pain or fibromyalgia. We have started using it for long COVID. Why? Because lignocaine has scientific benefits in COVID infection. I'm not going to go into the basic physiology and pathology, but if you need more details, I'm happy to talk at the end. But what happens is in COVID infection, this is a busy slide. Let me try to explain a bit. In COVID infection, the immunological mediators are the one which cause the morbidity. So patients who get cytokine storm, the release of cytokines from white cells or white blood cells, they are the one who get coagulation problems, vascular problem, and they end up with serious intensive care admission and even die. So cytokine storm is the one which we are struggling to control. And in cytokine storm, what happens is the patients have neutrophils. Neutrophils are a type of white blood cells. They form a net, they mix with each other and they form like a net. And this is the one which causes the major problem. And lignocaine in acute COVID has been found to break this net and reduce the cytokine storm, thereby reducing all the acute severe effects. So if this cytokine storm is going to cause the pain, we propose that this can help in long-term pain. I'll show you a picture. This is the sort of, I'm not going to go into more detail, but this slide I have put just to prove that there is research that there are mediators like high mobility group, colony stimulating factor, and toll-like receptor. These are the one which forms this net-like structure. And in white cells, this net is formed, and these are the receptors which block this and form a net which traps all the cytokine and other things and release it. And lignocaine or lidocaine blocks this pathway. That is why it helps. And there are other things which block the net formation also, which includes like colchicine and the cystic fibrosis enzyme that we use. It's very costly, this one, the DNA-ase enzyme. So we don't use it. It is only available in specialist centers like GOSH and other children's center where they use it. Colchicine is very commonly used in rheumatology services, but they didn't find very great results, but studies are still early days, so we don't know. And colchicine has various other side effects also, whereas lidocaine doesn't have those side effects. So there are evidences, I'm not going to go in detail, but there are papers which have shown that lidocaine reduces the net formation in various other medical conditions. And we know that net is the cause for COVID syndrome. So we are extrapolating and using this in resistant cases. We do use nerve blocks in pain clinics. So if you have specific headache problems or muscle related problems, which doesn't recover and you need some pain relief to engage them in your physiotherapy service, yes, we can do blocks for them. Regional blocks, pain clinics are very well placed to do those things. So we are experts in doing them. So if you look at this paper, this came from Wuhan in China. Of course, wherever the virus originated, they studied and they published this. What have they published? So this is a 6-month consequence published in January this year. They looked at, you can see here, 2,500 patients and 1,700 were followed up. 736 were excluded for various reasons. And the findings, I'm going to circulate here. 6 months after the infection, the patients are still troubled with fatigue, muscle weakness, sleep difficulties, anxiety, and depression. Of course, these are the same thing what I told in the beginning of the slide. So wherever the disease started or was noticed first in Wuhan, still they have noticed that many patients can suffer with this. So I'm going to finish here. I'll try to see whether I can play this video. Jenny, have I got another 3 to 4 minutes?
Yes, you have. Go ahead.
I'll see whether I can play this video. If you can't hear it, I'll stop it and take questions. This is a patient group who are shouting out about the pain. So let's see whether I can play this. If I can't play it, I have to convey my apologies and stop it here. But let me see, it's in YouTube. I'm sure I'll send the link. It is on that. Anybody can access this. Are you able to see the YouTube, Jenny?
No, but when you put your cursor over it, a link came up. So just move the cursor onto the wording.
Okay, just hold on, please.
We
Give
can
me a
hear
minute.
it.
Okay, give me a minute. I think I have to share that specific screen. I'll try and see, just bear with me for 2 minutes if you don't mind, because I'm changing the screen. If I don't get it, I will stop it. And let me know if you can see this YouTube screen now.
Yes.
Okay, I think it's loading slowly. Sorry for that.
That's all
I'll try
right.
to keep it like this. I don't want to enlarge the screen. Let's see whether it plays. And if it does, it will be great. Let's see. I'm sure if not, the link is there. I'll send it. And can you hear it?
Yes, thank you.
We're all members of a club no one wanted to join. Different backgrounds, ages, experiences. Thousands and thousands of us have been struggling for weeks and months with ongoing symptoms of COVID-19. These are some common symptoms, but there are many more. Some of us have been ill throughout, with others having relapses. We're still very ill. We're feeling pressure to return to work, to care for families, and get back to normal, when we still feel anything but. No one seems to be able to answer our questions or give reassurance. Will we ever get better? Will there be long-term repercussions for our physical and mental health? Is this post-viral fatigue, or are we still infectious? Will I be able to do the things that make me happy again? Can we hug our loved ones, or will we make them sick? Is this damage irreversible? Am I going to die? We just don't know, so we're sending out an SOS. Each of us has our own journey, but lots of us are feeling abandoned, dismissed, brushed off, ignored, and given conflicting advice. It can be hard for those around us to understand how ill we are. It's confusing and scary. Our numbers are growing and we need to be taken seriously. We need rehab, research, and recognition. We need to be believed, helped, treated with compassion, and supported by those around us. Please hear our SOS.
I think I'm going to stop here if you don't mind. And thank you very much for the opportunity. Special thanks to Jenny and Charlotte for organizing this. And I'm happy to take questions. I'm sorry, I have not seen the chat section, but if there